This is also where I reside, as in bipolar disorders or depressive disorders are, much like anxiety, very, very common. So there are different headings or different labels for the different mood disorders. You can have a major depressive disorder, or you can be persistently depressed, adjustment disorder, bipolar 1 or 2. Your depression may just cycle. It could be Pmdd, or due to a medical condition, or after ingesting a substance, or around your peripartum phase. So there are different reasons that could lead to one being depressed. So there are lots of different theories as to what can cause a depressive disorder. It is theorized that it could be from neurotransmitters, alterations in neurotransmitters. That is why, like your SSRIs, selective serotonin reuptake inhibitors, this is why they act on the neurotransmitters in your body. It is said it could be genetic. And I must say I agree with the genetic theory, because very often, especially in my adolescent population, if I have a teenage girl that's depressed, it is very likely one of her parents has depression as well. Not always, but it is very common that one of the parents also suffers from depression. It could be learned helplessness, could just be an offset of their character. It could be related to life events, life stressors. So there are lots of different reasons that play why one may present with a depressive disorder. And there are some people who have a depressive disorder and will not get treatment because of the stigma attached to having a diagnosis. I have one girlfriend who's a nurse as well, and she has an anxiety disorder, like it's really bad. We talk about it all the time. And she refuses to get treatment because she knows if she gets treatment, there'll be a paper trail saying that she has anxiety or that she's taking medications. So she rather suffers through the symptoms rather than get treatment, only because there is a stigma. When people hear about someone with mental health issues, immediately they start thinking, oh, they're crazy, I don't want to be around them. So, I mean, that's for those with limited thinking, but even so, in her own mind, she does not want to be labeled. So mood disorders affect a large percentage of the population. In the US, 1 to 3% often. It is diagnosed twice as much in women than men, and again, probably because women will show their emotions more or speak more about how they feel, but it is present in both sexes, women more so. It is thought that it has an earlier onset than once believed. It's not just for adults. I have 7, 8-year-olds talking about, I'm depressed. And I'm looking at them, I'm like, what do you know about being depressed? And sure enough, as they explain the symptomology, they are, in fact, explaining symptoms of depression. I mean, I'm like, what could have changed? What has changed in society? Why wasn't I depressed as a child? So something has changed from when I was a child, probably when you were a child. But in today's generation, depression, it goes across all ages. So nearly 2 out of 3 patients with one depressive episode will have a reoccurrence in 10 years. So if you know someone who was depressed for maybe a couple of weeks, a month or so, it is a surety almost that in the next 10-year period within that time frame, they will have recurring episodes. The severity of their first episode will predict the percentage of the reoccurrence, how likely it will be to reoccur. Like it is also said, like if someone has like a postpartum depression, that they're more prone to depression like in the future. So what are some symptoms of depression? When you look at your patients, what are some things you think you can see that would speak to the patient being depressed?
Lack of interest in doing things that they used to like to do.
Yes, this is the patient who used to love go down the hall to play bingo, and now they're saying, no, I'll just stay in my room, not talking, not wanting to engage, isolating in their rooms. Unkempt, yes, they're not attending to their daily hygiene because they don't have the motivation to, or very often they'll tell you they don't have the energy to. Most certainly. So as you interact with patients, you will get to start teasing these different symptoms out. And remember, it could be several different causes. So for a patient to have a depressed mood, they would need to have had sadness or anhedonia. Anhedonia is the inability to find pleasure in things. And they would have had these symptoms for at least 2 weeks. So I guess a day wouldn't qualify as being, I'm depressed. I guess I would say I was sad. But if it occurs in succession, then it goes on to depression. This patient can have irritability, anger, even rage. And this is sometimes I find that I often have to educate my patients about that. They're saying, I don't feel depressed. I've just been so down, and I'm snapping at everybody, and I'm just so restless, and I don't know why I'm so angry. And as they speak about those symptoms, you have to then educate them that, it sounds like you're describing the symptoms of depression. Hopelessness. I had one patient use that exact word to me today. It was a new intake. And she says, I've been having depression all my life. It's been increased for the past year or so. And I asked, what are your symptoms? Like, what tells you you're depressed? And she used this word, I've been hopeless. And as I use these words to you, you will come to realize that the patient who has been socialized in the psychiatric setting, they know these terminologies. The patient will tell you, I have demotivation, anhedonia, or they will even better state, I'm experiencing a lack of pleasure in enjoying things. So the patients are very versed on the verbiage very often. They can have feelings of worthlessness, difficulties concentrating or focusing. They can have difficulties in making decisions, sometimes feelings of guilt. So these are all different symptoms that can play into someone being depressed. It can manifest into physical symptoms. They could be agitated. There could be changes in their eating, whether it's eating too much or eating too little. So too for their sleep, sleeping too much or sleeping too little. This is why we assess sleep and appetite. Inertia, a decreased energy level, or just that plain old fatigue, like, I just feel so drained, not up to much. They could start isolating, withdrawing from family, friends, social interactions, missing work, missing school, calling out very often. So while they won't probably say, I've been isolating, like you trying to ask them, how do you spend your days? Well, you were going to work before, now you're not going to work anymore. So those are cues that the patient is probably isolating. And these signs and symptoms usually impact their function. So if they're a student, if they're an employee, it usually has some impact on their function in their lives. This patient can also have a preoccupation with death. My new intake today also, I think about suicide all the time. Do you have a plan? She goes, yes, I have been thinking about swallowing pills, like swallowing a bunch of pills. So of course, a red flag goes up. I'm like, I'm going to prescribe. How do I ensure that I keep her safe? She goes, well, I live with my sister, and my sister keeps my meds. So I had to talk to the sister, make sure the sister agreed that she would supervise the meds, keep them in a locked place. Otherwise, I would probably, one, if she has had any previous attempts, I would definitely order a visiting nurse to administer her meds daily with no history of attempts. And she's saying, I have a plan but no intent. I'd probably have the pharmacy bubble pack her medication so she only has maybe 2-3 days on hand at any time and not like a 30 days worth. So there are different plans you put in place as you assess your patients. So again, we look at suicidal ideations, plan, attempt, or previous attempt. Plan, ideation, or previous attempt. Today she had a plan, no intent, and no previous attempt. So this is the patient who will probably make for an easy shift for you because they won't act so much. They won't bother you. They won't call for anything. They'll probably just lay in their room, sleeping most of the day, or if not sleeping, probably just laying there. But this is not the patient for you to ignore or just say, oh, he'll be fine. This is the patient who you will actively work to try to engage. Try to engage that patient in completing ADLs, in eating, in ambulating. So this is the patient who will need that extra TLC on your shift because they just don't have the drive to engage in these activities. And as usual, for it to be a true depressive disorder, these symptoms that the patient is experiencing cannot be attributed to psychological results or substance use, or if they're grieving, has to be separate from those. So one form of depressive disorder is dysthymia. This is the patient who has that mild, long-term form of depression. You'll find some patients that tell you, oh, I'm depressed, I'll always be depressed, I'm never without depression. But this patient, while the symptoms are similar, they never reach the intensity of like a major depressive state. They will have 2 or more depressive symptoms and a depressed mood most days than not, often fatigue, low energy, low self-esteem. But they're never without signs and symptoms for more than 2 months at a time. So no more than 2 months at a time, never reaches the full level of a full-blown depressive disorder. So you're looking over your patient's history, you see dysthymia, it's a mild, long-term form of depression. So this patient is still probably engaging in daily activities, but just not to their full potential because they're having these depressive symptoms. You could have a patient who has an adjustment disorder. And as the word states, they have trouble adjusting to a change in their life. What are some changes that could happen in one's life that one could struggle with adjusting to?
Chronic physical illness.
It could be physical illness, yes. Divorce.
Loss of a job.
Yes, losing of a job. Moving, death. So there are lots of different things that happens in people's life. I have one patient who, well, I have more than one patient who have this sort of, one I can think of particularly is this woman that lost her husband. And she cannot, like her husband died and she has lost her sense of self. It was like Jack and Jill, and everybody knows that we are Jack and Jill, and now that Jack is gone, I don't know what to do with myself. Jack used to pay the bills, Jack used to do that, Jack would do this. And this has been like 3 years later, and she's still actively mourning the death of her husband. She quit her job, she started a new job, she quit that job too. She's not hanging out with friends, she's not, nothing. It would be as if the death just happened. That's because she's having difficulties adjusting to her new role as single, new role as widow, new role as breadwinner. So there's lots of different roles for her to assume, and she's having difficulties adjusting to this new role. So this emotional or behavioral, so the patient will have emotional or behavioral symptoms in response to the stressor. The symptoms can occur within 3 months of the onset of the stressor. It causes marked distress in excess of what would be expected. It causes significant impairment in their function. If it's not like a death, maybe it's loss of a job. Once the stressor has terminated, the symptoms do not persist for more than an additional 6 months. So you get a new job and you start improving, start getting better, and returning to your previous level of function. So when patients have a hard time adjusting, it could be an adjustment disorder with a depressed mood. So along with struggling to adjust, they could be depressed, or it could be adjusting with anxiety, or trouble adjusting with anxiety and depression, or trouble adjusting with a conduct disorder. Let's think of a child in a divorce. Now they have 2 different households, 2 different set of rules, and all of a sudden little Johnny that was straight A's is having failing grades, it's slamming doors, it's talking back to his parents. So that would be an adjustment disorder, adjusting to divorce with disturbance of conduct. Or it could be disturbance of conduct and mood. You take little Johnny into treatment, you realize little Johnny has depression and he's acting out. So it could present in several different ways. Or it could be an adjustment disorder unspecified. So you're not quite sure if they're depressed, anxious, but they're just not adjusting well. Any questions so far? Okay. So then we have bipolar disorder, which is usually not more popular, like a lot of people know about bipolar. And this is one of those disorders people are going, oh, I'm so bipolar, because they think about bipolar, and what do they think about? Mood changes. So anyone that has issues with mood, they quickly say, I'm so bipolar. So let's examine what a bipolar disorder is. It is characterized by the occurrence of one or more manic episodes. So this patient would have had one or more manic episodes. And what are some symptoms of mania?
Impulsive behavior.
Impulsive behavior. Anything else?
High mood, like euphoric.
Or yeah. What about their speech? Rapid. What about their thought processes?
Rapid and tangential.
Excuse me?
Rapid and tangential.
Yeah, they could have tangential, circumstantial speech, but what about the more psychotic features of mania?
It's like grandeur.
Delusions of so they can have hallucinations and delusions. Yes, they start having delusions. So those are all symptoms of mania. So the patient who has a bipolar 1 disorder would have had at least one manic episode, depressive episodes, and mood swings. So this patient can also have a hypomanic phase. And the word hypo means?
Lower or less than.
Right. So they will have those manic symptoms, the rapid speech, tangential, circumstantial speech. So it's not quite full-blown mania where they're having those psychotic symptoms, those hallucinations, delusions, but they will still have a lot of those manic symptoms, just not to the point where they're not functioning well. So they can still function in their daily lives without needing to be in an acute care setting. Or their behaviors could be mixed, or they could have a major depressive episode. Bipolar 1 causes clinically significant distress or significant impairment in a patient's functioning. The mood swings can last for weeks, even months. They can cycle back and forth from manic to depressive to baseline, manic to depressive to baseline. The cycles can vary in duration, and it's important to help the patient to determine their cycling. So we can probably get in touch with their providers. Maybe it's a time when they need increased medication or increased non-pharmacological services to help them to cope better. If a patient is having a manic, or if a patient is in a manic phase, what are some nursing interventions you think you could institute for this patient to help them through this phase? So let's picture the patient. You're working on the unit. The nursing station tends to be pretty. Is that the quietest place on the unit?
No, it's the noisiest.
You have a patient who is already amped up and talking a lot in this. Maybe you want to think about moving the patient to somewhere quieter. Is this the patient who you would have sharing a room or having a roommate? No, this is the patient who you want probably in a quiet area, a room by themselves, so you can decrease the stimuli or them being overstimulated, okay? So that's bipolar 1. Bipolar 2 is characterized by the patient having one or more depressive episodes and at least one hypomanic episode. So they have one or more depressive episodes with at least one hypomanic episode. So what's the difference between bipolar 1 and bipolar 2? Right away, that you can pick out.
Bipolar 2 is not as severe.
Yes, they don't have mania. They have hypomania. So when a patient says I'm bipolar, it's good to know bipolar 1 or bipolar 2. Even though the treatment is usually the same, just that with the bipolar one, you're going to see more of that psychotic symptoms with them. Depressive episodes last at least 2 weeks. The hypomanic episodes usually last 4 days. They've never had a manic or mixed episode. So if the patient tells you, once I had mania or I was manic, then it's not bipolar 2 because they never experienced full-blown mania. But just like bipolar 1, it will cause significant distress in their school, occupational, and all of the areas of their functioning. Here we have some symptoms of mania. We have listed some of them: abnormally or persistently elevated, expansive mood, irritable mood. It can last at least 1 week, or it could be every day, or most of the day. An inflated self-esteem or grandiosity, a decreased need for sleep. This is where we assess sleep. The patient tells you, oh, I don't need to sleep. I only take a nap for like 2 hours each night and I'm good. Okay, how about, are you taking daytime naps? If the patient says, yes, I sleep all day, then that explains it. But they say, oh, I don't need to sleep at all. I'm up all day. I'm working on my project. And this is a patient that has goal-directed activities, decreased need for sleep, they're talkative, they have a flight of ideas, they have racing thoughts, increased distractibility, increased sociability. Like, this is the patient, or this is your friend that never went anywhere, and every time you call her, she's out partying several nights a week. You're like, what is going on? These are signs of someone slipping into mania or in a manic phase. They may be very witty, and because of this, a lot of patients tend to enjoy being in the manic phase. It's almost as if they can't see the dangers of it or where it can lead them. So they kind of enjoy being there because they tell you. I have a few patients tell me, this is when I'm my sharpest, I'm at my best, I perform best in this phase. They usually have a goal-directed activity. They tell you, oh, I am cleaning the house, or I'm going to start a new business, or whatever their goal is. But they usually have some goal-directed activity, something that they're channeling a lot of interest in. I have one patient, she lives in a hypomanic phase, and she has this one goal of this online business. And it's almost as if when you watch movies and you hear about like therapeutic lifestyles and healthy eating and going away to some beachfront property and doing Reiki treatments. And so this is her dream. And she has built a website, but this patient is hypomanic. And she told me about the website, and I went on there and checked it out. And sure enough, she's out there advertising her business and getting clients. And she's hypomanic. She really takes her medications because she wants to be in this state. And maybe it's that little bit of mania that gives them the heightened creativity. I don't know, but it can go from hypomania to mania, and it can cause patients danger. They can start involving themselves in high-risk pleasurable activities. All of a sudden, your friend who would never date or go out with people, she went home with 2 guys. Like, what is going on with her? Or she never brought men home, or he never brought girls home, and all of a sudden, he brought a girl home from the club. Or just meeting a lot of people, having sex. Sex is a very common high-risk pleasurable activity they would engage in this manic phase. It causes marked impairment in social and occupational functioning. They may have psychotic features like hallucinations, and they may require hospitalizations to stabilize them. This is why sometimes when a patient comes in and I can notice these hypomanic symptoms, I will increase which drug? If I'm trying to treat manic symptoms, which drug would I be looking to make a change on? Antipsychotics. Those are the drugs that treat mania. What are some symptoms of hypomania? They're similar to manic symptoms, but they never reach the same severity. And they last at least 4 days. So this patient may have a decreased need for sleep, an increased sense of self, talkative, easily distracted, flight of ideas, increase in risky behaviors, increase in goal-directed behaviors. They may be very humorous and congenial, like really fun to be around. There's often a change in their usual functioning, but not impairment. So while they seem somewhat high-strung, they still be engaged in school, engaged at work, taking care of their family, but you can notice a marked change in what you know is baseline. This patient is not in control of their moods or behaviors. Again, it does not cause them marked impairments. So they probably tell you having a lot more fights with their spouses or their... Someone speaking? So sometimes the patient can have a mixed episode. This is when criteria is met both for manic episodes and a major depressive episode nearly every day for at least 1 week. The patient is both manic and depressed. They have rapidly altering moods, and it causes marked impairments in their functioning, and they may even have psychotic features. So you can see sometimes bipolar disorder mixed. So sometimes patients will have their diagnosis, and if you look at the end of it, it will tell you with psychotic features or mixed episodes, so you can get a better idea of how this patient presents. Cyclophymic disorder, and as the name says, cycles. It lasts for at least 2 years. The patient will have numerous periods with hypomanic symptoms, cycling with some depressive symptoms. So hypomanic and depressive symptoms. The signs and symptoms, only 1 year, if it need to be present for only 1 year if it's a child, or if it's an adolescent under 18 years. They never meet the criteria for a major depressive disorder. So even though they have these depressive symptoms, they don't have major depression. And they're never without symptoms for more than 2 months during those 2 years. So more often than not, they will have those hypomanic symptoms and those depressive symptoms. It will cause clinically significant distress in this patient's functioning, but there's no major depressive symptoms, and they're not manic. And they're not having mixed episodes either. And we have PMDD. This is the premenstrual dysmorphic disorder, which a lot of patients say they have. You'll hear it very often. This is a patient that has at least 5 symptoms that is present in the final week before the onset of your menses and starts to improve within a few days after the onset and becomes minimal or absent post-menses. So I have some patients who, during that period and around their menses, I have to increase the dose of the SSRI, and the order is written as such, or they'll have extras where they can take around that time, and then we'll decrease it after. They'll have marked affective lability, which means changes in their moods. They can be irritable or angry. They'll have a depressed mood, even hopelessness. They can have anxiety as well as tension, a decreased interest in usual activities, difficulty concentrating, lethargy, change in appetite, hyperinsomnia, or just feelings of being overwhelmed. So you're probably thinking PMDD is just someone PMSing, but it is a true disorder, and patients do suffer through these symptoms monthly. Any questions so far? You guys are super quiet. Okay. So sometimes patients can have a mood disorder that is due to a general medical condition. What are some medical conditions you think could present that would lead to a patient having a change in their mood?
Thyroid problems?
Thyroid problems, definitely. Chronic illnesses, vitamin deficiencies. So lots of things can present. It's characterized by a depressed mood or marked diminished interest in all or most activities, or it could be an elevated or expansive or irritable mood. It'll cause this patient significant distress. It could also be due to a substance being induced. And this is why I tell a lot of my patients, which I had to share with a patient today. This is the same patient who I had her intake, who told me she was having suicidal thoughts and felt hopeless. I said, are you smoking? Are you drinking any alcohol? No. Using any kind of illicit drugs? She said, yes, I smoke weed. I'm like, how much weed are you smoking? A lot. All day, every day? I was like, oh, so has anyone ever told you that marijuana use affects your mood? She goes, no. So I had to educate her about the effects of marijuana and how it plays on her mood. Do you have an interest in cutting down on your use? No. So as we go on, I would recommend that she gets into therapy so she can get some insight or work on gaining some insight into her treatment and rationales and treatment recommendations. And then hopefully we can get her to the point where she can reason through her substance use and her moods to see if we can address them there. So this is prominent. This is a prominent or persistent disturbance in mood, which is characterized by one or more of the following. The patient will have a depressed mood or markedly diminished interest or pleasure in all or almost all activities. They can again have elevated, expansive, or irritated moods. Evidence that the symptoms develop during or within a month of substance intoxication or withdrawal. So further assessment would be needed for this patient. I just had her intake today. So now I need to see, was there a period when you were not using marijuana? When did the symptoms present? Oh, I started smoking weed when I was about 18, so maybe around 18 and a half, 19, I started having these symptoms. So it could be the weed, I don't know. So you kind of tease these different things out to see if it is related to the marijuana use. How are you when you don't smoke? Well, she's telling me she's smoking all day, every day, so she probably doesn't know. So how about we try to get you off the weed and see how you do? So lots of different questions to ask patients. Depressive episodes surrounding the peripartum onset. It meets the criteria for major depression with signs and symptoms appearing during pregnancy or within 4 weeks after delivery. So this meets the criteria for a major depressive disorder. Symptoms would last at least 2 weeks. They're not just the baby blues. Some patients may also experience psychotic features. I can remember historically in the media you'll hear of mothers drowning babies, or mothers killing kids after giving birth. So some patients can have command hallucinations or delusions in this depressive state. And the risk is increased even more with subsequent pregnancies. So if they had some depressive symptoms in the next pregnancy, they'll more than likely have worsening of symptoms. So this would be treated like any other depressive disorder, but of course you'd have to touch base with the PCP, like if the patient is breastfeeding, like you want to make sure you're prescribing safe, or that a patient is taking drugs in a safe manner. How do we treat these depressive disorders? Therapy. Cognitive behavioral therapy is most effective. This is where it seeks to examine the patient's thoughts and see if you can then effect change on their behavior. Of course, it could be medications. And we know that which class of drugs treat depressive disorders?
SRI, SNRI.
Yes, the SSRIs, SNRIs, tricyclics, MAOIs, they all treat depressive disorders. Sometimes I'll recommend that patients do group therapy. Sometimes they can see that they're not alone, that other people have experienced the same thing, other people are improving, other people have weathered the storm. Sometimes they engage in the group therapy, they'll form a little network, meet someone, have friends outside of group. So sometimes group therapy can have its benefit, or you'll have those patients who tell you, I will never do group therapy. Those patients who are not responding to treatment, they could do ECT or some deep brain stimulation. And the pharmacology repeats itself because we looked at it earlier in earlier lessons. It's the tricyclics, the SSRIs, the MAOIs, and bupropion, which is also used for depression. Remember, you're teaching your patients about side effects, expected onset of action, like how soon the patient should expect the drug to start working, how often they will be taking the medication. So you can tell them it's not like you wake up sad this morning and you're going to take the pill today and not for another few days because you're feeling better. These class of drugs, tricyclics, SSRIs, MAOIs, Wellbutrin, are all meant to be taken on a daily basis. For a patient with a bipolar disorder, the gold standard of treatment for a bipolar disorder is lithium. So you think bipolar, you think lithium. They're also treated with Lamictal, and there's another one that's not listed here. It's Latuda, Depakote, and Tegretol. These are all medications used for a bipolar disorder. You'll notice that you have Depakote and Tegretol there. So you think bipolar, you think moods. So you use mood stabilizers, the lithium, the Lamictal, the Latuda. It can also be treated with anticonvulsants, off-label, but they seem to work, and that's the Depakote and the Tegretol. Important to educate your patients if you're taking lithium. Lithium requires frequent monitoring. One, to check the lithium level. The therapeutic lithium level is 0.6 to 1.2, something very important for you to know. You should educate your patients that these drugs could be for long-term use. They have many side effects, so you want to educate them as to what the side effects are. You want to teach them to avoid activities that leads to heavy sweating, as the risk of side effects of lithium is increased if the patient is dehydrated or even excessively hydrated. So you want to make sure they're avoiding dehydration. Some side effects of lithium. As I mentioned, you monitor blood levels regularly. Therapeutic range is listed here. It's toxic if it's 1.5 and up. Some signs of toxicity: increased thirst, increased urination, lethargy, seizures, coma. These are all important things for you to know. You encounter a patient on your unit, they tell you, I'm so thirsty, I'm using the bathroom all the time, I'm having seizures. You look at their med list, you see lithium. It's probably a good idea to point out to the provider this patient's taking lithium. I'm seeing signs of lithium toxicity. So knowing your lithium toxicity, signs and symptoms, lithium level are all important things to know in the world of nursing. I mentioned Lamictal is also widely used. It's a mood stabilizer. You should educate your patients if you're taking Lamictal that they can get a rash. It's a rash that usually occurs in the first couple of days of use. It's usually on the chest. If they notice a rash, they should stop the medication, notify their provider. Other signs of lithium toxicity could be flu-like symptoms, dizziness, blurred vision, and headaches. So education is key. And I always, it's almost like a double-edged sword sometimes, because while it's good practice to inform the patient of the potential side effects that they have, what do you think happens on the other side of making them aware of the side effects?
Create the side effects.
Yes, without a doubt. Oh, Zoe, I think I'm getting a rash, and I thought I had a seizure. I'm like, oh. But we still have to educate them. We still have to educate. So usually you'll see that in the patient with some anxiety. If the patient has anxiety, that is when you start seeing them feeding into it, worrying about it, thinking it's going to happen, because that plays into their anxiety. So especially like when I have children with anxiety, I will try to tell the patient, the parent, what the side effects are, because very often that child is going to start having those side effects. But it is good practice. We have to educate them nonetheless. Depakote is a drug. It's an anticonvulsant that is used to treat mood disorders as well. Like lithium, it requires a blood draw. Fasting, usually 12 hours after the last dose. The therapeutic range for Depakote is between 50 and 100 micrograms per milliliter. They need frequent CBCs, liver function tests. It can cause damage to the pancreas. Lithium often causes damages to the kidney, And this is why, even though it is the gold standard of treatment for a bipolar disorder, I will very often start with another mood stabilizer like Latuda or lamotrigine before I use lithium, because I'm trying to save these patients' kidneys. I have so many older patients with kidney disease because they took lithium for all these years. And some patients would even refuse to get off lithium because it works. So they'd rather risk losing a kidney or kidneys than change to a different drug. Because just imagine a patient who was at one point totally debilitated by their mental illness, and now to have found a drug that works, they will take that drug at all costs because they can remember what their life was prior to not taking that drug. It's supposed to read micrograms per milliliter. I am pretty sure. I did realize it said milligrams per milliliter right there. Some signs of toxicity for Depakote: fever, sore throat, GI upset, alopecia. So these are things you wouldn't need to know offhand, but you would have access to these levels you can inform your patients about. Micrograms, MCG. Other drugs, Tegretol, you'll see prescribed very often too, carbamazepine. You're welcome. Also requires weekly testing. It has a level listed there, 6 to 10 milligrams per milliliters. Also very toxic to the liver. And it's used particularly for rapid cycling patients. So those ones that go from mania to depression, depression to mania in a quick fashion. Any questions? So I am not sure why my screen wouldn't show the other night, but it did show for me last night. So this is, we're going to do some Cahoots. So Cahoots is, I would say, pay attention to Cahoots, pay attention to the topic in Cahoots. It's something I put together and students have found it very helpful. We have covered so much material that it's so hard to say. As a student, I'm sure you're like, where do I start to study? So I've put Cahoots together, and we usually do it a few classes. It covers some of the topic areas that you should focus on. Let me see if I can get that going tonight. Share. Not sure why it wouldn't share the other night, but let's go. Oh my gosh. I wonder if it's my laptop that's not allowing me to share. Okay, so unfortunately, I'm going to have to go downstairs and log in from my desktop, okay? So give me a second here. We're going to take a 10-minute break so I can get downstairs and log in, and then I'll see you at 6:10 for Cahoots.